Well, hello and welcome. Welcome to Diverse Conversations with Ashka Patel. And today it's an absolute honor to have our guest, Dr. Bruce Berger, joining us for the conversation on motivational interviewing. It is one of the most important tools a pharmacy or a healthcare provider, for that matter, can have in their toolkit. And I'm just very, very excited to unpack this with him because he has been a leader when it comes to implementing motivational interviewing and how it can help achieve patient outcomes, in particular treatment adherence. Bruce is a president of Berger Consulting, LLC, and professor emeritus at Auburn University. He has developed a course called COMMIT, which is Comprehensive Motivational Interviewing Training for Healthcare Providers, and AUMITI, which is Auburn University Motivational Interviewing Training Institute. He has taught motivational interviewing in healthcare and methods for improving treatment adherence for over 30 years. Bruce received his bachelor's in pharmacy from the Ohio State University. And after practicing in pharmacy for 2 years, he returned back to Ohio State, where he received his master's and PhD in social and behavior pharmacy. His research interests include health behavior change and improving treatment adherence. He has written 3 books, written or presented over 900 papers, 88 of which are peer-reviewed, and seminars on these topics. He has attracted over $3.5 million in funding to support his research. He has been a consultant and a trainer for numerous national and multinational organizations and businesses where he teaches motivational interviewing to healthcare providers and to any other professionals. Bruce is the 2009 recipient of the American Association of the Colleges of Pharmacies Robert Chalmers Distinguished Pharmacy Educator Award, one of the association's three highest honors in pharmacy education. He's also the author of the book Motivational Interviewing for Healthcare Professionals, A Sensible Approach, with August 2020, where his second edition had come out. And also, he has developed an 8-hour accredited motivational interviewing e-learning program for healthcare professionals in 2015, along with his colleague, William A. Villome. Today, Bruce, I'm very excited to welcome you to this conversation, as I'm certain that the expertise and the experience that you bring in not only just teaching, but also preparing healthcare providers to truly set up our patients for successes, it's going to be critical as we unpack this topic and really, kind of learn about why it's so important, and sometimes a rather not so well thought topic in pharmacy school, especially when we talk about it here in Canada. And I'm just really looking forward to hearing your perspectives on it.
Yeah, great to be here. Thank you for asking me.
Thank you. So I guess we'll start off with a very simple question, but I'm sure it's a question that carries a lot with it. What is motivational interviewing? And, let's start off with that and see how we can go forward with it.
Well, in the simplest kind of explanation, it's not only a set of skills, but it's a way of being with patients. It's a patient-centered approach, and it was developed for patients who are ambivalent or resistant to changing their behavior. It originally was developed by a clinical psychologist named William Miller, and focused on substance abuse. And, when I read, it is still the most successful intervention in substance abuse today, lowest rate of relapse. And, when I first discovered it, probably 35 years ago, I started thinking, wow, if he could do this with people who are addicted to substances, can't we bring this to healthcare for high blood pressure, diabetes, and chronic disease management? And so, again, it's a set of skills and a way of being with patients. And we use those skills and a way of being to explore and uncover the patient's motivation or lack of it.
Right.
It's really a misnomer in that we are not doing motivational interviewing to motivate patients. We're doing motivational interviewing to understand and explore the patient's motivation. What's keeping them from doing something? What would make it more likely that they would take their medicine, lose weight, quit smoking, whatever the behavior is? And it's done in a non-confrontational way.
Fantastic. Thank you for sharing that. And again, like, I think you've kind of alluded to this already, but, from the research and the extensive involvement that you've had with motivational interviewing and like, the benefits, what are the benefits of MI, when we are providing, I guess, patient consultations using motivational interviewing, what are some of the benefits for both the healthcare provider as well as the patient?
Well, I would say that, an important benefit up front is that motivational interviewing is evidence-based. It's well-researched. And so, a lot of people will say, oh, we should do this or we should talk this way, but there's no evidence behind it. There's tons of research on motivational interviewing. I know we'll talk a little bit more about that later because we've done some of it. But one of the most important things is that motivational interviewing doesn't cause face loss.
Right.
When I have the opportunity to do a lot of work consulting for companies that are doing MTM, medication therapy management, and when I listen to the calls, around 80% of the conversations have face loss. Face loss occurs when we're saying things to the patient like, no, that's not how you're supposed to take it. Or we've been over this before. Or did your doctor tell you? So some kind of correction or scolding in a sense. And what we've learned is that when people lose face, when patients lose face, they stop listening. Right. Or they discount the information that's being given to them. So motivational interviewing doesn't cause face loss. It can be used effectively in time-limited environments, which is what healthcare professionals face all the time.
Yes.
And fundamentally, it honors and respects the relationship and the patient's right to choose. I like to use this analogy. We get trained in healthcare thinking we're driving the bus and the patient's a passenger.
Yes.
The opposite's true. We don't drive the bus. The patient has always driven the bus. The patient ultimately decides. We tell a patient everything there is to know about a medication and why it's important, but ultimately the patient decides. Right. What we're trying to do is uncover up front, how motivated is the patient to do this, what might get in the way, or downstream, what's caused them to stop. Right. But ultimately, we're a passenger trying to influence the direction of the bus. Right. That the patient is driving, not us.
That is very, very true. And again, I think that kind of goes back to the whole theory where we want to keep the patient as the leader or the driver of their healthcare, right? And we are there to support their healthcare needs.
What it means to be patient-centered. It's not about me, it's about them.
Exactly.
And the fact is, and I don't mean this in any kind of negative way, it is their illness. So they have to decide if they want to treat it. Right. Now, we can have huge influence on that, both positively and negatively. Motivational interviewing's influence, according to all the research, is very positive.
That's fantastic. And I do want to unpack the evidence around motivational interviewing, very shortly. But before that, you had touched on this topic of, the time that it takes to come, it's not very time consuming. And as you have rightly pointed out, time is of essence when it comes to providing healthcare. What are some of the barriers to motivational interviewing, and, how much time does it take to complete an effective motivational interviewing?
Well, I would say that one of the biggest barriers, honestly, is insufficient training. Right. I get asked all the time, will you do 1 to 2 hours of training in motivational interviewing? And I always respond that 1 to 2 hours is not training. It's an introduction. And, Miller's research and my research shows that you need a minimum of 8 hours of training and a lot of practice to get good at it. Now, the reason that's so important to your time question is that if you do not have the appropriate training, you can spend a heck of a lot longer with a patient than you need to. Exactly. On the other hand, how much time it takes is dependent upon how complex the issue is. Also, if you have we had a patient who for example, was prescribed an anticoagulant because they had the other kind of MI, myocardial infarction. And this patient said to us, they put a large bottle of aspirin on the counter.
Right.
And when we asked, is it for you? Their answer was, listen, I've already had the lecture. Aspirin's the only thing that gives me relief from my back pain. So yes, I'm going to take it. And I've heard what the doctor said, but I'm still going to take it. And no, I'm not going back to the doctor for blood work. Now, that's not a 2-minute conversation, But on the other hand, using MI, we can get that down to under a 5-minute conversation, even with something with that complexity. Because we have to first, the first things most of us say in situations like that is, well, that's not a good idea in one form or another. We looked at the guy and we said, aspirin's been the only thing that's been giving you relief from your back pain. And you don't want anybody taking your pain relief away. That's really important to you. And then we said, I don't want to take your pain relief away either.
Right.
Then we told him what our concerns were. Right. So by first telling him that we get what his issue is, he was more willing to listen. And that's part of what MI does. The other thing I'll tell you is that Miller, in his research, showed that 5 minutes of motivational interviewing done by an expert, that's the key, an expert, is more effective than 30 minutes of traditional counseling in healthcare.
Wow.
Which, by the way, is not counseling. It's education. Counseling is an exchange of information. What we call counseling in healthcare is really us telling the patient something.
What to do.
That's right. Or education.
Right.
And let me give you a really quick example. I was working, and I've had permission to use this example. I was working with a number of Kroger pharmacists, Kroger being a large food chain here. And they have pharmacies. And they said to me, we've got a patient. He's got a medication for his blood pressure. Supposed to take it every day. All of his data shows that he takes it on average 4 days a week, right? They call him up, hey, Mr. Jones, we notice you're taking your blood pressure medicine 4 days a week. You really need to take it every day if you want to get your blood pressure down. He always says, yeah, I know. This is what they're telling me. He always says, yeah, I know, I need to do better. And guess what happens next time they talk to him?
He's back to what he was doing before.
That's right. And I said to the pharmacist that I was working with, when you tell him you need to take it 7 days a week, what do you learn?
Right.
And they said, nothing. And I said, that's correct. I said, what would happen if instead of saying you need to take it 7 days a week, you said, hey, Mr. Jones, we notice you're taking your blood pressure medicine about 4 days a week. What's made it important for you to take it on those 4 days? Will we learn something? And the answer is sure. We'll learn something about how important does he think this medicine is in treating his blood pressure. We could also ask him, then we can use that positive conversation, because now notice we've noticed what he's doing, what he is doing. Yes. We always talk about non-adherence, but non-adherence means they're also, unless they're not taking it at all, they're also adherent.
Exactly.
So let's focus on the adherence and find out why they're being adherent on those 4 days. That'll help open up the other 3 days. So we'll learn something. He may say, hey, I take it 4 days a week. I feel fine. So I decided I really didn't need more than 4 days a week. So now we can say, okay, because you were feeling okay, you thought 4 days a week might be enough. He says, right. And we say, that makes sense. Would you mind if I share a few thoughts with you? And you tell me what you think.
Right.
Then we can do the education about why 7 days is needed, even though they feel okay.
And that's a great point you raised there, because it's really about perspective, as you really mentioned, right? Because I think we as healthcare providers, we think, oh, that it's the 3 days that the patient is not taking medications, but we fail to acknowledge the 4 days that the patient is actually taking the medication.
And it's really largely our training is,
Yes.
Again, we call it non-adherence,
Yes.
But it's also partial adherence.
It is, yeah.
A woman that had diabetes once looked at me and said, I'll take the medicine, but don't expect me to do anything else. Well, when I listen, and we hear this all the time, and when I listen to calls, the very first thing the pharmacist says in some respect or another is, well, that's not enough.
Right.
Well, they may be right, but that's face loss.
Yes.
Right?
Yes.
And we're losing the patient rather than, I'm really glad to hear that you're committed to taking the medicine every day. What's made that important to you? Exactly. Now we can affix her motivation to the other behaviors, but it's coming from her, and we're acknowledging what she's doing. This is actually called positive psychology. It was developed by a guy named Seligman, and it's very powerful. It's one of the reasons MI works, because we're actually focusing on what patients are doing, not just what they're not doing.
Right. And that's actually great. And you had mentioned about, it being a non-judgmental conversation, a conversation that kind of speaks to the patient's motivations. And, now that I reflect back, even the term non-adherence in itself is a judgment that we are passing, because, what are we expecting the patient to be adherent to? Our instructions, that really, again, then kind of goes to show, what patriarchic type of a model that we have created that we need to start looking back and,
yeah, we used to even call it non-compliance.
Yes,
that was worse because they're not dogs and children. They're human beings who have a right to make decisions. Exactly. Sometimes those decisions can get them in trouble, but we shouldn't be judgmental about it. We should be, again, exploring what they're doing. And I really want to emphasize again, we're not trying to motivate them or persuade them. We're really trying to explore what they're doing, provide new insight, so that they may change their mind. Right. For example, the person who says, I don't understand why I need this medicine, I feel fine, and they have high blood pressure or diabetes, right? Right. Well, in our sense-making approach that we develop, we have found that a sense leads to a conclusion, which leads to a decision about behavior. This patient's sense is, I feel fine. Right. What's their conclusion? I am fine. Fine. What's their decision about behavior? I don't need to do anything. Exactly. And the fact is, human beings use what are called schema to make sense of things. One schema that's common in healthcare is, if I feel fine, I am fine. Well, guess what? Most of the time that's true. Yes. Right? Except for asymptomatic chronic illness. Yes. So rather than immediately saying to this patient, just because you feel fine doesn't mean you are. You could have high blood pressure and not feel it. And you hear the comma stupid at the end of that sentence and the face loss, right? Yes. MI would say, so because you're feeling okay, you're really wondering, why do you need to take this medicine? And in fact, your wondering is a skill we developed in our book and in our e-learning that is used whenever the patient is saying, I don't get it. And that's what notice what it does. Also, it turns that patient's statement into a question. Yes. That we now can answer. Got it. And we can now tell them how they can feel fine and still be at risk. And that's the piece that's missing from their motivation. That is that they don't understand how they can be at risk if they feel okay. Exactly. Notice now, when we were talking about time, I can't tell you how many times I've listened to healthcare professionals, pharmacists, go into a long explanation with this patient about the etiology and progression of high blood pressure. That's not this patient's issue. Their issue is they don't understand how they can feel okay and be at risk. Right. That's what must be addressed. That can be done in 2 minutes if you know what you're doing.
Exactly. And I think it really starts with allowing the patient to be the decision maker and us being the presenter of information and being able to then have an engaging dialogue where both parties are equally contributing.
Right. And at the end of that dialogue, we always end up saying, once we've provided new information, we don't say, therefore you need to take the medicine.
Yes.
We say instead, where does this leave you now in regard to taking the medicine? Because I want to know, did this new information have an impact?
For sure.
And in what way?
Exactly. And I think it's a very critical component because oftentimes we present so much information to patients that, we don't even gauge their capacity to absorb that information before, providing all that information to them. And then we expect them to kind of just follow it. But how are they going to follow it if they don't understand the information that we provided to them?
And when we open the door and say, where does that leave you now?
Yes.
They may have they may have a perplexed look on their face, or we might even hear the nonverbals over the phone. They may say, well, and then we could say, sound like you're having some doubts.
Right.
Tell me more about that. Right. And we want to know, because if we don't uncover that, they're going to go back home and not take the medicine.
Exactly. And and I think as healthcare providers, we've always been kind of driven or, motivated by evidence supporting our practices. And you had alluded to this a little earlier as well, but what evidence exists to really demonstrate the importance of motivational interviewing, especially in chronic disease management? Like if there's any evidence you would like to highlight?
Well, there's tons of it, and time when that. If pharmacists go to PubMed.com, PubMed.com, and they put in evidence of MI effectiveness, they'll find tons of research. But I'll tell you one piece we did, and we actually won a national research award from the American Pharmacists Association called the Wiederholt Prize for the best publication in the social behavioral sciences. We got asked by Biogen to if we could help them. They've got a drug, Avonex, for MS. They had a 13% dropout rate on the drug.
Wow. And
so we did a huge study for them, and and to make a long story short, it was a clinical control trial where we had a treatment group and a control group, and people were randomly assigned to the treatment and control group. The only difference between the two groups were we did 4 months worth of motivational interviewing interventions in the treatment group. Control group got what they got before. Okay. And this is through Biogen's call center, by the way. At the end of the study, the treatment group, the dropout rate dropped to 1.2%.
Wow.
That was a projected savings to Biogen of $93 million. In addition to the fact that people who would have dropped out from taking the medication stayed on their Avonex. And the most important thing about this study is there were groups of patients. Every patient, of course, is different. There were groups of patients that were thinking of dropping out because they had needle phobia.
Right.
So we could help them with that. There were other patients that said things like, I'm taking the Avonex and I've had a flare up again. I don't think it's working. They didn't understand that it was still working, but it was going to slow the progression of the illness. It wasn't a cure.
Right.
And so again, even there, rather than saying to them, well, it's not a cure, stupid, right? And causing face loss, instead we said, you've been taking the medication and you had a flare up, and that really made you wonder, is it working? And we would then say, that's a great question.
Right.
Then we could say, unfortunately, as of today, we don't have any cures for MS, but this medication can slow the progression and strength of those events. I fear that if you stop using it, your MS would progress much faster. What are your thoughts now? Right. Okay. Another group of patients, for example, had a hard time tolerating the side effects in the first several months, which go away. and we could help them with that. And of course, there were patients that had combinations. But the fact is, we were able to individually tailor the help we were able to give those patients and reduce the dropout rate in a hugely statistically significant way to 1.2%.
That is fantastic. I mean, and I think
that's been published.
Exactly.
It was published in JAFA.
Wow, that is an incredible example. And I think, and kind of just to, take this evidence a little bit forward, how can pharmacists use MI in their roles, be it in community consulting, MTM, whatever role that they have. I think I'm starting to see like MI does have a huge role to play in terms of how we provide care to our patients, and like would love to just hear your insights on that.
Yeah, let me tell you about something that's very sad first. Okay. There's a company called Precision Value. Okay. And one of the things they do are studies and polls. And so they polled healthcare professionals broadly and found out one of the most important critical issues for healthcare professionals is treatment adherence. Wow. And yet, and even though they cited helping patients become more adherent is one of the most difficult things for them to do, less than 50% were using evidence-based approaches, including MI, to do that. So here we have an evidence-based approach, and look at what happened with the Biogen study, and there's many other studies like that. And yet healthcare professionals are not using those approaches, or if they use the approaches, they don't have the proper training to use them effectively, and then they blame MI. All right. And the fact of the matter is, I'm working with a number of MTM companies here in the States, and one in particular, Aspen RX Health, through my consulting, has now made me one of their health coaches. Wow. They are so convinced that it's made a difference in the calls that they make to their patients that they've broadened my role. And so I do a lot of work with their pharmacists. And again, these are 15-minute, 20-minute calls. But honestly, that's probably more time than most retail pharmacists have. Yes. But on the other hand, the results are pretty impressive. The pharmacists will tell you they feel so much better about themselves at the end of the call because they feel like they've made a difference. All right. Exactly. Even in approaching patients about flu shots before COVID, they would ask a patient if you had a flu shot, and the patient would say, "No, I'm not, and I'm not going to get one because it gave me the flu last year." Right. And the first thing they would say is, "It can't give you the flu." And now we're in an argument. Rather than you got the flu shot last year and then you felt bad, felt like you had the flu, so you're thinking, why in the world would I want to do this again? Right. Now we're saying to the patient, we get it. Got it. Then we can help them understand how you can feel bad for a day, right? But it doesn't give you the flu. But you've got to first acknowledge and respect what they're saying. Same thing with COVID. I can't tell you how many times I've heard people say to a patient, I don't want to take that drug. That they can put a computer chip in there and they can monitor you. And the response immediately is, that can't happen. Exactly. Rather than when you heard about that, you thought to yourself, I don't want to get a vaccine where somebody can invade my privacy. So we've got to acknowledge and respect what the patient has to say if we're going to have an impact, even if we don't agree with it. I agree. And I think, again, this kind of takes back to the crux of the matter is we need to listen to our patients and not necessarily be the ones kind of teaching them with the finger pointing, saying you do this or whatever you're saying is wrong, because that's really where the face value and the loss comes in. It is called health care. Yes. It shouldn't be an oxymoron. Yes. In other words, part of being caring means to be, even if a patient says, I don't want to take that COVID vaccine, it can give you COVID, right? Even though we know that's not true. Yes. You have to be able to respect and hear the concern of the patient. and say, you don't want to take something that could give you the very thing you're trying to prevent.
Exactly.
And the patient, am I agreeing with them? No, I'm saying I get why you don't want to do it.
Right.
Then we can say, would you mind if I just shared some thoughts with the idea that this is really your decision?
Mm-hmm.
They can hear that.
Yes. Got it. And that makes a huge difference, right? Because then the patient, I think right now, the whole difference of opinion, and I mean, you're already seeing the polarizing views around even this whole pandemic and everything related to the pandemic. And I think the way you stated, it really helps the patient feel heard, and which ends up then making them more receptive to the information that we have to share with them as well, right?
Yep.
And I think when
you can't get there by correcting them.
Exactly. And
That's
I think
why I say face loss is deadly.
Yes, we lose them the moment we say no, or we try to demean them or anything like that. We lose them right at the get-go instead of even allowing us an opportunity to present our side to them. So
yeah, I always tell healthcare professionals, if you can add the word stupid to the end of the sentence and it doesn't change your meaning, you're going down the wrong path.
Right.
Now, when you say to a patient, you can't feel when your blood pressure's up,
yes,
stupid, right? Then you're down the wrong path.
Got it. Fair enough. And with that said, any critical research papers or research that you have done that really highlight or show that pharmacists are able to improve patient care with the use of MI?
Well, again, let's put it this way. I do have pharmacies and pharmacists or organizations that have done that and shown effectiveness. Mm-hmm. But it's proprietary, so I can't share it. Okay,
fair enough.
Because it was done with me helping them as a consultant. But again, there are studies with pharmacists and physicians, etc. I was working with a company whose primary care physicians. They saw tremendous increases in patient satisfaction with care. Right. With their physicians that had been trained in MI.
Right.
They also found, believe it or not, after they got good at it, it took less time. It allowed them to actually take less time with the patient because they got to the patient's issues quicker.
Issues first. That's true. And I think it really drills down to knowing what are the concerns of the patient in the truest forms, rather than us kind of guessing or projecting our own concerns onto the patient without even truly understanding their situation, right?
Or talking about things that's really not what the patient's stuck on.
Exactly.
When the patient says, I don't know why I need this medicine, I feel fine, mm-hmm. That's the issue that needs to be addressed, not how high blood pressure evolves.
Exactly. And with that said, you have practiced as a pharmacist in the past, and you teach extensively, motivational interviewing, but also you have a lot of work done in terms of improving treatment adherence. And how can pharmacists better contribute to improve patient health outcomes, from your perspective?
Well, and I'm biased in that to me. Back in the early 1970s, somebody named Bonnie Svarstad, who was a researcher at the University of Wisconsin, mm-hmm. College of Pharmacy. She was actually has her PhD in sociology.
Wow.
She did a huge study and found that the number one predictor of adherence and outcomes was the relationship between the patient and the healthcare provider. And here we are 40 some years later, and we're talking about digital health. All of those things are extremely important tools.
Yes.
But it still boils down to the relationship, and so we have got to be able to learn, whether it's MI, how to explore a patient's motivation to manage their illness. We have to learn how to explore, how is this patient making sense of it, of their illness and treatment? We ask questions like, what does diabetes mean to you, in your own words? Because that's going to uncover for me, where is the education needed? Mm-hmm. How do I know what to tell a patient if I don't know what they understand? We call motivational interviewing, by the way, a meeting of experts.
Right.
As a pharmacist, I'm an expert on drugs. The patient's an expert on how they make sense of those drugs and the illness that they're treating. And so if I say to a patient, tell me in your own words, what does diabetes mean to you? And the patient says, well, you know, the doctor says I have sugar, but I feel okay, so I don't see any point in doing anything.
Right.
The patient's telling me something about how they're making sense that's really critical to me now knowing how to respond to them.
Yes.
Versus the patient who says, oh my gosh, you know, if my doctor said if my blood sugar remains elevated, I could have kidney problems, go blind. I don't want that to happen. Those are two very different patients.
Right.
And how I respond to them, you know, and so I need to find out, you know, what would make it more important to treat the, you know, to treat the diabetes, what gets in the way. And we've got to stop these paternalistic and persuasive approaches. We have 40 years of evidence that they don't work. I mean, I'll leave you with this. Think about this. 40 years ago, the rate of adherence in year 2 with a chronic illness was less than 50%.
Wow.
The rate, okay, 40 years ago.
40 years ago.
Back then, we said the reason was that we had 4 times a day and 3 times a day drug therapy. It was harder to take. Now we have once a day, once a week, once a month, once every 6 month drug therapy. Guess what the rate of adherence is now? Still
the same or lesser?
Absolutely the same. You have to ask yourself, why?
Why?
Yeah. And my answer is the way we talk with patients has not changed fundamentally in 40 years.
Yes, that's true. That's true.
And when we do change and use things like motivational interviewing, the rates of adherence do go up.
For sure, for sure. And you have brought such an interesting statistic because, you know, it really goes to show how much behavior and personal beliefs have a role to play, you know, when we're dealing with, you know, patients' attitudes towards taking medications. Do you want, like, are there any other tools or resources that you foresee pharmacists requiring that can help them better support patient outcomes? I mean, like, I think I'm convinced about the importance of motivational interviewing. Like, you have convinced me, that's for sure. I think every pharmacist should be very well versed with motivational interviewing and should be using this as part of their day-to-day interactions with patients. Any other resources which are, you know, effective to the level of motivational interviewing that
well, you know, what's interesting is that all the research that's being done on a lot of interventions you know are showing, you know, 5 to 10% increases, you know, if they're done consistently. But what I see is you know, a dynamic. It's not either this or this. It's not either digital health or motivational interviewing.
Right.
These are tools, you know, and when I see the, you know, and this probably leads to, you know, one of your next questions about the future, you know, we're talking a lot about digital health. Digital health conferences are coming up everywhere, and it's absolutely vital.
Yes.
The devices that patients now can use, in terms of, you know, little watches that can track their sleep, can track their walking, and, you know, so many different things. Those are all things patients are going to be getting more and more feedback about their own health. But ultimately, we're still going to find that patients are going to be non-adherent or partially adherent, right?
Yes.
And we still ultimately have to learn how to talk to them in a way that doesn't scold, that doesn't threaten, etc. So we're going to be using digital health to uncover it. There's a digital health product right now that, for example, uses a chip that can tell with an asthma inhaler whether how often the inhaler was used and whether it was used properly, so that the patient got a full dose. All right. So now the information goes back to the pharmacist or the physician and says, patient's not either using the inhaler correctly or not using it often enough.
Right.
Now we got to talk to them about this.
Yes.
Are we still going to scold them?
Nope.
Or are we going to explore what's going on in a caring and loving way?
Exactly, exactly. And you've raised such a great point. It is like, yes, the whole focus is on digital health, and that's because it's that untapped territory which we're just emerging into. But at the same time, I think, as you said, 40 years ago, it was the relationships that mattered the most. And today it's the same thing. And 40 years from now, it's going to be the same thing. It's going to be that human interaction and human connection.
What I find troubling is, I was part of the academy for 40 years of my life, right? And if academia is not about evidence-based and research, what is, right?
Exactly.
And yet, here we are 40 years later, still trying to figure out what to do. And we have evidence-based approaches that work, yet the work of, precision value study shows that less than 50% of healthcare professionals are using these evidence-based tools to have an impact.
That's true. That's
true. And then, and I'm going to scold the academy a little bit. MI is now part. I don't know what it is in Canada. It is part of accreditation standards in the U.S.
Okay.
But very few schools train 8 hours of motivational interviewing training. And yet the evidence shows minimum of 8 hours to be effective, right? Wow. So they do a couple hours, and often the people teaching it are a new clinical pharmacist and they've been stuck with the course. Right. It's not going to work.
It's not. And
by the way, just so you know, we're giving our 8-hour MI e-learning course to AACP to allow the schools to use it for student use only.
Wow.
On a yearly basis. Pharmacists who want CE will still need to go to our Purdue website. And by the way, we're accredited for Canadian pharmacists also. So
that's fantastic. I'll be sure to link that course in our description box below, just so that if anyone who's listening is interested in checking it out, please do check it out. I'm in the process of taking that course right now. And if anything I can tell you is motivational interviewing is important. It's a skill that we need to learn to better support our patients moving forward, because and this is again a question I also want to explore with you a little bit further, but I really do think that pharmacists will have a very huge role in patient education and just patient monitoring moving forward. And like, I think motivational interviewing would be a critical tool to have for us to have any success, with our patients utilizing technology, medications, be it in any way, shape, or form that they're prescribed, to make sure that they're, taking it the way they should be to get the outcomes that they want to achieve out of those. Well,
and the way our health system is moving in the U.S., and I can't speak for Canada, but the way we're moving in the U.S. is we have now what are called star ratings, where patients are rating the care they've been given.
Right.
Where we're moving is two things. If your star ratings are too low, your compensation is not going to be equal, not going to be where you want it.
Right.
And if you do not show positive outcomes, your compensation is going to be lower.
Wow.
So, and not only that, we don't need pharmacists to dispense drugs.
Exactly.
We have machines that can now dispense far more accurately.
Yes.
And so, I see a day coming when the dispensing is done in an off facility and, sent to patients, and the pharmacists are going to be doing this,
exactly.
You and I talking digitally.
Yes.
And we're still going to have to know how to use motivational interviewing with this medium.
Exactly.
And pharmacists will be able to work at home like they're doing in the US with MTM right now, which is huge.
Exactly.
To be able to talk to patients and have an impact.
No, that you're so right on that, and it's interesting. I mean, we don't have the star ratings fully implemented just yet. We do have a private provider, an insurance provider who's testing it out right now with pharmacies and pharmacists, but we're not there yet where, it's fully integrated into our profession. However, that said, what happens south of the border does influence our profession in a few years. So I would not be surprised to see this wave of, changed expectations coming to pharmacists and the profession of pharmacy. And, I think we need to be forewarned so that we can prepare for that future. With that said, any advice for pharmacy professionals as we're preparing for the future?
Just really understand that if you're clinging to dispensing, yes. Look, I understand that right now where we are is that too much of what we get compensated for has to do with the dispensing of a product.
Yes.
That's not our future. Mm-hmm. It will not be our future. We will know that we've gotten to where we want to get to when we don't dispense a drug and get paid.
Yes.
In other words, where we see this drug is inappropriate for this patient, mm-hmm. and we don't dispense it and get compensated.
Exactly. Wow.
And so that's where we have to be moving toward. Mm-hmm. And again, I can't stop people from dispensing right now because that's still where most of the compensation is coming from, yeah. But it's not our future. The fact that MTM is growing so rapidly in this country, and the fact that pharmacists are being paid by health plans, yes. to call seniors, and talk to us about our medication, that's the future.
Yes. I agree. I agree for sure. And again, I think we share a similar vision when it comes to that, because I really do see the role of the pharmacist stepping away from the dispensary and more so connecting with the patients one-on-one. And, we are seeing an emergence in digital therapeutics where, there's like games and softwares that are designed to help, improve patient behaviors and outcomes. Again, these systems or technologies are only as good as the support that the patient gets. And I think pharmacists will play a critical role because we are known as the medication experts. We will be then the natural, by default, the healthcare providers will be stepping in to educate our patients, because if we don't, then somebody else will.
Well, and I've worked with several companies now also that are developing mm-hmm. digital assistants.
Yes.
Okay. And so the digital assistant can actually, the computer and these computer voices are getting really good.
Yes.
Where they can actually, send an email message or call up the patient, however the patient wants it, mm-hmm. and say, Mr. Jones, it's time to take your
medication.
Or Mr. Jones, I noticed from your Fitbit that you haven't done your walk today. Are you still planning to do it? Now, those are things a digital assistant can do. Yeah. What these companies know now, because I've done workshops with them, we are nowhere near the level of complexity of being able to do MI with yes. a digital assistant, yes. because these are complex human interactions. Mm-hmm. So at the risk of a really bad pun, pharmacists have got to make themselves indispensable mm-hmm. by building effective relationships with the patient. Yes. It's not going to be by the drugs we dispense. It's going to be by the relationships that we build with the patient.
So true. And what a great note, to kind of end our talk. But I do want to make sure, and I reemphasize this, that, we will be linking the course that you've created, because it is 8 hours of motivational interviewing training for healthcare providers. It's a dedicated course created for healthcare providers. And the good thing is it's accredited for US and Canadian, pharmacy and healthcare providers. So,
and technicians.
I'm sorry?
And pharmacy technicians.
And pharmacy technicians. There you go. So, I think we should all be preparing for the future, which, as Bruce mentioned, it is evolving. And if we need to make ourselves indispensable, we need to build on those relationships. And I cannot think of a better tool than motivational interviewing to really support those conversations in a productive way, right?
What I'll also do, Ashka, after we're mm-hmm. done is sure. There are some additional resources, like for pharmacists who wish to pursue being consultants. Mm-hmm. American Society of Consultant Pharmacists does yes. that. I'm going to send you the names. One person, I don't know if you've ever heard of Blair Thielemeyer. Blair is somebody that has helped pharmacists become independent consultants and make money at it.
Wow.
There's an organization called Metapreneurs that does the same thing. And I'll send you the links to their sites and you can share them with your pharmacists.
I definitely will be doing that for sure, because any information we can get, especially like, MTM is still not a fully tapped in market here in Canada. So I think we're all kind of just learning the ropes when it comes to, how do we integrate and become MTM consultants. So the resources you highlighted would really be of benefit to everyone who gets access to this podcast. Thank you so much, Bruce, for sharing all that information with us. I will definitely be sorting. So make sure to check out Bruce's book. It's available on Amazon and American Pharmacists Association, as well as the course that he has designed, which is available at Purdue's e-learning website, which will be linked below in the description box. So please feel free to check that out. And again, reach out to Bruce. He's available on LinkedIn. So anytime you have a question, he has, we connected over LinkedIn, and here we are having this conversation. And, he has been a great support in teaching me the ropes of motivational interviewing, and, what came up as an interest in learning about the theory behind it. And now I'm actually pursuing this topic. It really is, for me to have a mentor in Bruce has been great. And Bruce, thank you so much for sharing all that information with our audience today. I'm so grateful.
Yeah, my pleasure. I've enjoyed it.
Awesome. Fantastic. Well, stay tuned for our next episode coming up very soon. Till then, bye-bye.